Hello there and welcome back. This is part 2 of the anatomy review where we're going to go through the actual structures you should be able to identify on a radiograph, specifically the intraoral radiographs. We'll start with the maxilla, then we'll move to the mandible. If you want to watch a longer video where I actually point out these structures on a skull, so maybe it'll help make sense why things look the way they do in a radiograph, follow the link in the description below. It's the same material, just a little bit more in depth, a little bit longer. So remember, this is review material where I go through a lot of material that I already taught in the first year course. And so I'm going to move fast. If something doesn't ring a bell, go back to that first year course material and brush up. All right, first one here, this thin radiolucent line in between the teeth in the anterior maxilla, that's the intermaxillary suture you can see in these two different radiographs. Like I said, I'm going to go fast. So this second one, this V-shaped opacity that you can see right here, you can see here on the skull, pointing out why it looks the way it does. It's a little projection of skull. And that bony projection is where some of the nasal septum cartilage attaches. That's the anterior nasal spine, ANS. And then going laterally from the ANS, ascending upwards, as you see here in the skull, you have the opening of the nasal fossa. That's the nasal aperture. Here you can see in some of these examples. And so however you want to call that, the opening of the nasal fossa, the nasal aperture. Here, what are we pointing out here? This is actually the inferior turbinate on the left side, also called the concha. And this midline vertical structure with the bony and cartilaginous components is the nasal septum. So 3 structures on the nasal cavity: the aperture, the concha, and the septum. So this one right here is really similar to what I just showed you. It's the anterior nasal aperture, the opening of the nasal cavity. Here we can see we're looking at a canine. But as you project further posteriorly, sometimes even in the posterior radiographs, you can see this straight line extending posterior. In this case, anterior is over here, posterior is over here. And it's not the maxillary sinus, which we'll cover in a few minutes here, but this is actually the floor of the nasal cavity. You can also call it the hard palate line because it's 2 sides of the same coin. And then sometimes you'll see this radiolucent oval in between the 2 maxillary incisor roots. That's the incisive foramen, also called the nasopalatine foramen. It's the inferior opening of the nasopalatine canal, which we'll cover next. The canal extends through the anterior palate like this, and of course there has to be an opening for every canal, and sometimes you'll see that overlap the roots, sometimes it'll be in between the roots, sometimes more distinct than others. So incisive foramen when you see that. But here I wanted to focus on the canal itself. You see these well-corticated lines extending upward from the nasopalatine foramen? That's the nasopalatine canal. Now this is a 3D view. It's actually behind where the roots of the teeth are. Here we have an axial slice, so it's a horizontal slice to the patient showing the same thing. These are the teeth number 8 and 9, the central incisors, and just posterior to that is this well-defined round canal structure, your nasopalatine canal. Here we can see looking down through the nasal cavity in a skull, and you can see those superior foramina. It's rare to see in an intraoral radiograph, but sometimes you do if you get a steep enough angled one where you can see the bottom of the nasal cavity. And you can see the superior openings of the nasopalatine canal, or superior foramina of the nasopalatine canal. And in this case, we see a radiolucency around the apex of that lateral incisor. This is not an uncommon thing to see, and that's because there's this fossa, usually right around the apex of that lateral incisor. But you can imagine a little depression here, sometimes called the incisive fossa or the lateral fossa. And don't mistake that for a periapical hypodensity. Sometimes it looks even more discrete than this. Just know that there are natural impressions in bone, and so you have to be aware of those. All right, so what's this structure right here? It looks like something overlapping the roots of the anterior incisors. It doesn't have a corticated line. Maybe you're guessing it's a soft tissue structure, but how does it get there? So imagine you're taking an intraoral image and it's slightly superiorly angulated, and you project the tip of the nose over the roots of the teeth. And so that's just soft tissue of the nose. See the outline right there? So nose, soft tissue. Sometimes you'll see it from the side and you'll see the ala or the wings of the nose, and that'll be projected a little more laterally. We can imagine that over the lateral incisor or sometimes the canine. All right, you probably know this one, the maxillary sinus. Sometimes that dips down in between the roots of the teeth. Sometimes it's more hypoplastic, meaning small, and it doesn't really go down between the roots of the teeth. So there's variation to this, but it should have a nice, well-defined corticated outline as we see here. All right, and what are these 2 structures that you see here? Notice the canine, incisor toward the left, premolars toward the right, and so this is more anterior, this is more posterior. More anterior, you expect to see the floor of the nasal cavity. The aperture of the nasal cavity may go up like this, but the floor extends backwards. I pointed out that straight line of the floor that extends backwards, and you can even see in posterior radiographs sometimes. And so this one again is the maxillary sinus. Be aware that the sinuses continue to pneumatize over time, so older patients may have really large maxillary sinuses as it continues to grow or pneumatize. And also be aware there's a specific name for when these two lines cross, the floor of the nasal cavity and the floor of the maxillary sinus. Sometimes they merge to form an inverted Y here. In this case, it forms an X, but we'll refer to that sometimes as the Y line of Ennis. All right, review of these structures. If you see a well-defined radiolucent line extending through the bone, good chance that's a neurovascular canal. Sometimes in the sinus, we get these well-defined straight lines that are just septations of bone, so a sinus septum, just little plates of bone that you may see. And now this one is my favorite structure, so if you don't know this one, you really should. So if you get one thing from this lecture, what is this? This kind of curved, backwards J-shaped structure. If you saw it on the right side, it would look like a forwards J shape. But this is not part of the maxillary sinus. If you look closely, you may see bone extending posteriorly from it like this. And so what are we looking at in the skull here? You can imagine the maxilla curves outward to join with the zygoma, which is the cheekbone right here. And there is a suture in between that we don't see from this angle. And so you can see the zygoma extending posteriorly. But what shows up on the radiograph is this little saddle-shaped piece of bone of the maxilla, and we call that the zygomatic process of the maxilla. So definitely know that one. If that doesn't rattle off your tongue, say it about 10 times until it does. All right, and what do we have in this case? Would you guess another hard tissue or soft tissue structure? There's no cortical outline to it. It's just more dense over here, or more radiopaque, more light. That's a soft tissue structure, but what makes that? Maybe hard to tell in this image, but this is a premolar, and this is more anterior toward the left, posterior toward the right. This is just that fold of skin that some people have more prominent than others, and that's called the nasolabial fold. All right, this one may be tough to conceptualize unless you're familiar with anatomy, so look at your skulls. But posterior to the maxilla here, the maxillary tuberosity, you have the pterygoid plates, as we see in this skull image here. The lateral plate's larger and is more visible. Sometimes you also see the hamulus that extends down from the medial plate. It's that little hook-shaped projection off the medial plate. Rare to see it clearly, but in this image you can see it really well. That's the hamulus. This crossing over the hamulus is more likely the lateral pterygoid plate. So be aware of that. You'll see it in intraoral and in panoramic radiographs. All right, now on to the mandible. Same drill, we're going to go through each structure we need to identify in the mandible in our intraoral radiographs. All right, so what's this here? This is an occlusal radiograph, if you're not familiar with it. It's as if you're kind of looking top down at the patient, but just seeing the mandible. And there's a little projection on the lingual surface of the bone. You can also see that in your intraoral radiographs, but it just shows up as usually round or sometimes irregular, well-defined radiopacities. But roughly in the center of the anterior mandible, the genial tubercles, also called the mental spine sometimes, that's where the genioglossus muscle attaches and the genial hyoid muscles. And the muscle pull over time is what makes the tubercles more prominent. So spine of bone or tubercles, so just remember both these terms, mental spine, mental tubercles, or genial tubercles. And then sometimes in or around those genial tubercles, you see the small radiolucent dot. And that has a really simple name, just the lingual foramen. Usually it's right in the center of the genial tubercles, but there's a lot of variation. You may see multiple lingual foramina. So just know what it's called, know that there is variation to it. You may see several. If you've never seen this before, it might be confusing, but if we get a steep enough image, you can see how that ridge of bone on the mentum, on the chin, can project over the intraoral radiograph. It is a bony structure, and that's just the mental ridge. What about if you see an ovoid radiolucency like we see here? Does this look like a periapical lesion or other pathology? It has kind of a gradual border to it. And so do I suspect some malignancy, something bad? Well, this is why we need to be aware of these different anatomical structures. And this again is just a fossa or an indentation in bone that happens to overlie the mandibular anterior roots. And so we call that the mental fossa. I always think of mental floss when I say that, so that may help you remember mental floss, mental fossa. All right, and this one you absolutely have to know as a dentist. It's a well-defined, round, usually ovoid radiolucency, and it can superimpose right over the roots of some of these teeth. Usually the second premolar, but sometimes the first premolar or even the mesial root of the first molar. And every dentist I've talked to has a story of someone else that made the mistake and did a root canal on one of these teeth because they thought the mental foramen was a periapical inflammatory lesion. Of course, nobody's done that themselves, but they've always observed someone else that did that. So don't make that mistake. That's a rookie mistake. All right, and this one's pretty easy. If you see a nice, well-defined radiolucency going down through the center of the posterior mandible, you can see it going up the ramus a little ways. But why in some cases does it look more opaque? This is the mandibular canal, also called the inferior alveolar canal, and it does have a cortex around it. And so in this case, it doesn't look that radiolucent. Usually it does look radiolucent like this, though. A lot of times you're going to analyze that and its relationship to the roots of teeth that might need to be extracted. So another important one to know. All right, what did I say about when you see radiolucencies extending through the bone, especially when it goes to the apices of the teeth, or some of these go, you'll notice they go in between the teeth and to the alveolar crest. And these are all just nutrient canals. Similar to what I showed you on the previous slide with the mandibular canal. In a lot of cases, these are surrounded by a sclerotic corticated border, and they can appear more dense. You'll see that quite a bit going up to the mandibular molars, but they're just nutrient canals. All right, what about this one? You see this dense ridge of bone extending downward from the anterior border of the ramus, and then a lot of times it'll cross over the roots of the mandibular teeth, and that's just the external oblique ridge. Here we see it on a skull. Then a lot of people confuse this one for the external oblique ridge, but remember the external oblique ridge should merge with the anterior border of the ramus, and sometimes it does cross over the roots of the teeth. But the internal oblique ridge, or the mylohyoid ridge, usually is further down from the roots of the teeth. It doesn't really connect to that anterior border of the ramus. A lot of times it will superimpose over the mandibular canal, so that can get confusing, as we see here. It superimposes over the superior border of the mandibular canal. Here it's separated, so there's variation. It can also be varied by what the angulation is when that radiograph is taken. Here we see in the skull why that occurs. There's just this ridge of bone. The submandibular gland sits here and creates the submandibular fossa, and there's a lot of fatty tissue in there as well, and so the bone develops around it and forms this ridge that can show up in your radiographs. And so I just mentioned what this one is, but you've got this fossa here related to fatty tissue and the submandibular gland, and so we're going to call that the submandibular fossa. Then you won't see this very often in intraoral radiographs unless it's taken somewhat steeply from below, but that's just the inferior border of the mandible, so be aware of that. And this is another rare structure to see. It's a mandibular structure, but it's showing up in a maxillary radiograph, and that's when the coronoid process overlaps your maxillary radiograph. So I've seen one example when a dentist thought this was a tooth root. He planned to go in and extract it. Luckily, he took another radiograph and confirmed that there was nothing there. He was just looking at the coronoid process of the mandible, so that can project in some cases. All right, be able to identify these 30 structures. This list is not completely comprehensive, so check with me and make sure you have the most updated list, because I'll sometimes add and take away from this, just to keep things interesting, you know. All right, then a couple things specifically just for interpretation. First one, cervical burnout. This is the radiolucent appearance that you see around the cervical region of teeth. Sometimes it can be mistaken for root caries. So two things create it. First, subsurface scattering of x-rays. It's the same physical principle as shining a light through your hands. Everybody's done that when they're a kid. You have a flashlight, you shine it through your fingers and see that red glow. But x-rays bounce and refract inside the tooth material. And then the second thing that causes this is enamel above this dark cervical region, and bone exists below it. And so that's another thing that creates a radiolucent appearance here in between the enamel and the bone level. And the combination of those effects creates a darker appearance, and that's what leads to cervical burnout. It can look a lot like root caries, but it isn't. We'll talk about this more when we get to the caries lecture. All right, last thing here, don't make this mistake. Is this a periapical inflammatory lesion? Do you expect to see that on a tooth that hasn't even erupted? Probably not. I did see on a dental internet forum when someone was asking, why do these teeth have periapical inflammatory lesions? They're not even exposed to the oral environment yet. Or is this some other pathology? Well, hopefully you get familiar enough with developing teeth. You can see the crowns are completely developed and the root's not fully developed. These apices are open. And while those apices are open, you'll have this well-defined radiolucency at the apex. That's not pathology. It's just a forming tooth root. So don't think that needs any treatment. And so that covers it for maxillary mandibular structures. Again, if you want to watch a similar video that I made last year, it's a little more detailed and I point out structures on a skull. A lot of people like that video because they like seeing how it lines up on the skull and how that projects on the radiograph. Follow the link below in the description. But in the next and last radiographic anatomy video, we'll do a quick panoramic anatomy review. And so I'll see you on that one. Thanks.